now we'll have Dr. Carla Moran talking to us about syndromes of resistance to thyroid hormone, which is quite a challenging subject too. So please enjoy.
I'm going to talk during this talk about the syndromes of resistance to thyroid hormone. So we talked a little bit already about how thyroid hormone is produced and how it circulates in the body. But with reference to this talk, I'd like to just mention a little bit about the key target organs for thyroid hormone action. So almost every cell in the body expresses the thyroid hormone receptor and has the ability to respond to thyroid hormone. But when we think about the organs that are particularly relevant for this talk, I'd like to mention the muscle, because thyroid hormone affects the metabolic rate. The bone, where thyroid hormone is important for bone maturation, bone turnover and growth. The central nervous system, where thyroid hormone has an important role in brain development and myelination. And the heart, where it exerts inotropic and chronotropic effects. And the liver, where it affects the production of SHBG and also has a major role in the metabolism of cholesterol. I mentioned already that thyroid hormone predominantly works by binding to the thyroid hormone receptor, and indeed thyroid hormone exerts the majority of its effects through this pathway, through the genomic pathway. But when we think about the thyroid hormone receptors, it's important to note that there are two main forms of the thyroid hormone receptor, and these are thyroid hormone receptor alpha and beta. And there is tissue-specific expression of these receptors. So the skeletal muscle, bone, CNS, and heart predominantly express the alpha form of the receptor. The liver, the hypothalamus, and pituitary predominantly express the beta form of the receptor. And that's a really key concept when we're trying to understand the pathogenesis of the various forms of resistance to thyroid hormone. So when we think about resistance to thyroid hormone, this can occur at various levels in the pathway of thyroid hormone action. So the resistance can occur at the level of the receptor itself, either due to defective signaling through the alpha receptor or the beta receptor. There can be defective signaling due to defects in thyroid hormone transport, and these are mostly MCT8 defects. And there can be abnormalities in thyroid hormone metabolism. And most commonly, this is selenoprotein deficiency. For the purposes of this talk, I'll talk about the syndromes indicated here as 1, 2, and 3, and I won't cover selenoprotein deficiency because it is exceptionally rare. So I'd like to start off by discussing a case of a patient who's under my care. So he's a 42-year-old man who was a teacher and competitive swimmer. And he presented with acute left face, arm, and leg weakness. And unfortunately, he was found to have an acute infarct in the right MCA territory. He had had a background history of paroxysmal atrial fibrillation since the age of 30, and this had proved quite difficult to control. He also had a history of anxiety. So he had an acute stroke and went on to have thrombolysis. And during this time, his atrial fibrillation was quite difficult to control. And unfortunately, the initial stroke was further complicated by a second stroke. He developed an occluded basilar artery. He required thrombectomy, and this was further complicated by hemorrhagic transformation. So he had quite a devastating stroke and had a protracted inpatient stay and is having ongoing rehabilitation and has only just started to walk again with the aid of a stick. So a devastating effect, devastating event for this young man. Of relevance to us is that he had abnormal thyroid function tests. So he'd raised T4, raised T3, and a TSH within the normal range. And so as I spoke about earlier, there's a number of different causes for this pattern. And we first sought to exclude assay interference, and then we thought about other potential conditions. And so he had sequencing of the THRB gene, and this is the gene that encodes the beta form of the thyroid hormone receptor. And he was found to have a heterozygous mutation in that gene, which was known to confer resistance to thyroid hormone beta. So this is his diagnosis. But it's important to think about whether this diagnosis is relevant to his presentation and what it might mean for him. So let's think a little bit more about resistance to thyroid hormone beta. This is an example of another child who was diagnosed with the condition. So these patients have mutations in THRB, and they have defective signaling through the beta form of the thyroid hormone receptor. It was first described in 1967, and the frequency is 1 in 19,000 individuals. The majority of patients have missense mutations, like the patient I've described, but some patients have frame shift or premature stop mutations. The vast majority of patients are heterozygous, but some patients are homozygous, and they tend to have a more severe presentation. The mutations affect the T3 binding domain of the receptor. And so the majority of patients have abnormal T3 binding. Most patients have inherited the condition in an autosomal dominant fashion, but it can arise de novo. The age at diagnosis is very variable, and the phenotype is also very variable. In common to all patients is abnormal thyroid hormone, thyroid biochemistry. So what is shown here is the TSH, T4, and T3 of over 80 patients with mutations in THRB. So you can see that the patients tend to have a normal TSH, as indicated by the blue shading. They all have a raised T4, and they almost invariably have a raised T3. And the other thing you will note is that the T4 elevation can be very variable. So some have a T4 that's slightly elevated, whereas others have a T4 that's almost 4 times the upper limit of normal. The abnormalities in the thyroid hormone biochemistry reflect the resistance within the hypothalamic pituitary thyroid axis, because the HPT axis expresses the beta form of the receptor. The liver also expresses the beta form of the receptor, so we would expect that the liver is relatively resistant to the effect of thyroid hormone. And to look at this further, we measured lipid profiles in a large number of patients with resistance to thyroid hormone beta. And we found that their LDL level is elevated, their triglyceride level is elevated, and their HDL level is lower than controls. And this is a lipid profile that's reminiscent of the metabolic syndrome. So we went on to look at other features of that condition. And the patients have raised intrahepatic lipid. They have raised intramyocellular lipid. And in keeping with this, they have insulin resistance as measured by an elevated HOMA-IR. So we feel that these findings reflect resistance at the level of the liver to thyroid hormone action. And you may remember that patients with conventional thyrotoxicosis tend to have a raised SHBG. And these patients with RTH beta, although they have raised T4 levels, they tend to have an SHBG that is within the normal range. And again, this reflects hepatic resistance to thyroid hormone action. But as I've shown you, they've got raised T4 and T3. So one might expect that they have increased thyroid hormone exposure to those tissues which express the alpha normal form of the thyroid hormone receptor. And that is indeed what we see. So the heart rate in patients with RTH beta is elevated compared to euthyroid individuals, but not quite as high as what we see with thyrotoxicosis. And the rate of atrial fibrillation was 6% in this study. It's worth noting that the average age in this study was 42 years. So that rate of atrial fibrillation is 20-fold higher than one would expect for that age range. We know that thyroid hormone has a key role in controlling our basal metabolic rate, also termed resting energy expenditure. And patients with thyrotoxicosis have a raised resting energy expenditure. Patients with RTH beta also have a raised resting energy expenditure, and it's in between that which we see in controls and thyrotoxicosis. And again, perhaps this is not surprising because our basal metabolic rate reflects the energy expended by our skeletal muscle and heart and liver. And so these patients would have relative thyrotoxicosis in the heart and skeletal muscle, but resistance in the liver. So this is a summary of features of RTH beta. So we have resistance within the axis. So they have abnormal biochemistry. The majority have a goiter. And in the liver, they've non-raised SHBG, dyslipidemia, and raised HOMA-IR. And in tissues that express the alpha form of the receptor, they seem to have some thyrotoxic features. So they've raised metabolic rate, failure to thrive in childhood. Adults have reduced bone mineral density. Children can have short stature with later catch-up and growth. They can have poor attention and concentration, reduced IQ, and anxiety is frequently described as its hyperkinetic behavior in children. Patients frequently complain of palpitations. They have an increased risk of arrhythmias, and severe cases can develop cardiac failure. So if we go back to our case, we measured his lipid profile and screened him for diabetes, and these tests were unremarkable. I felt that he had relative cardiac thyrotoxicosis because of the atrial fibrillation, and so I felt it would be beneficial to lower his thyroid hormone levels. So I used carbimazole to lower his T4 and T3, which was effective, but you can see with time that his TSH is really rising. There was a benefit from a cardiac point of view in that his palpitation frequency reduced. He went into sinus rhythm, and we were able to reduce his beta blocker dosage. But what will we do in terms of the TSH, and is this a concern? So if we think a little bit about how we usually manage RTH beta, so the first thing to say is most patients don't require any specific treatment. They may have relatively few or no symptoms. But if patients have palpitations, we use beta blockade. If they have predominant pyrotoxic features, such as the patient I've described, we use antithyroid drugs to lower the thyroid hormone production in the gland. But this reduction in thyroid hormone stimulates an increase in TSH production. And that increase in TSH can stimulate further growth of the thyroid gland. It could potentially overcome the block at the level of the thyroid gland induced by the antithyroid drug, and it could potentially cause pituitary hyperplasia. So in some circumstances, we add in another medication, Triac, triiodothyroacetic acid. This is a thyroid hormone analog that preferentially binds the beta form of the thyroid hormone receptor. And so it lowers TSH and hence can help lower thyroid hormones as well. And so this is a medication that I'll add in for this patient. So I'm going to change tack a little bit now and speak about resistance to thyroid hormone alpha. So here the level of resistance is at the thyroid hormone receptor again, but it's defective signaling through the alpha form of the receptor. These patients have a mutation in THRA, the gene encoding the alpha form of the receptor. And this condition was quite recently described in 2012. The frequency is not known, but greater than 50 families have now been described, and more than 20 different heterozygous mutations have been published. Patients can have frame shift, premature stop, or missense mutations, and the mutations again affect the T3 binding domain. And so they can affect the binding of thyroid hormone, but they can also affect the interaction of the thyroid hormone receptor with cofactors. Patients can inherit it in an autosomal dominant fashion or de novo, and it's most often diagnosed in childhood. And again, the phenotype is very variable. These are the first 4 patients who were reported to have the condition. And they have some features in common. So they're all short. They have an increased head circumference, and they all had problems with developmental delay and to a variable extent, reduced IQ. The first child, the 6-year-old on the left of the screen, had a very protuberant abdomen, which you can see there, and she had very profound constipation. The patient on the right had a very severe learning disability to the point where she had been institutionalized her whole life, and she could only speak in single words. These are some other patients who have been described since then, and there are some facial features in common, which I'd like to draw your attention to. So they tend to have a broad face. with a flattened nasal bridge, an elongated philtrum, thickened lips, and they often have skin tags. All patients have a neurological phenotype. A history of delayed developmental milestones is very common. It's reduced IQ, and patients often have a slow dysarthric speech. They can have a type of cerebellar syndrome in that they have slow initiation of movement, an ataxic gait, dysdiadochokinesis, and motor incoordination. And they have been reported to have seizures and possibly an increased frequency of autism spectrum disorder. Although their head circumference is enlarged, their brain volume is reduced, and we can see that on MRI imaging. They have skeletal features in common. So in childhood, there's delayed closure of the fontanelles. There can be persistence of the skull sutures. Epiphyseal dysgenesis is also common. Delayed rupture, a rupture of the teeth, and delayed bone age. Adults have generalized cortical thickening, and prominent frontal bone is common. I mentioned that the first patient described had very severe constipation, and in fact surgery was being considered prior to a diagnosis of RTH alpha. And you can see very clearly here in the plain film of her abdomen that she had very dilated bowel loops. She was only passing a bowel motion every 2 weeks, so it was very uncomfortable for her. The curious thing about resistance to thyroid hormone alpha is that we don't have that biochemical signature that we see in RTH beta. So biochemistry can be completely normal, and this really makes diagnosis difficult. And it probably explains why we have only recognized this condition of late. If the biochemistry is abnormal, you might see a low T4, a raised T3, low reverse T3. TSH is usually normal. Creatinine kinase can be high, and this probably reflects skeletal muscle hypothyroidism, and an anemia is quite common. This is a summary of the features of RTH alpha. So in contrast to RTH beta, the resistance is in the alpha expressing tissues. These patients can have a low metabolic rate. They tend to be obese. Adults also have skeletal adults tend to have a high bone mineral density. CNS features I've mentioned. They can have a mild bradycardia. And the normal thyroid function tests probably reflect the fact that the beta form is expressed in the HPT axis. And so thyroid signaling through the axis is not perturbed. Patients can also have an anemia, as I mentioned, and they may also have macroglossia. So it's difficult to know how to treat these patients, but all of the patients described are heterozygous. So they do express a wild type receptor. So we've treated these patients with thyroxine in the hope of supersaturating the wild type receptor and see if we could perhaps relieve some of the resistance at tissue level. So this is the growth chart of the first child who was diagnosed. So she started on thyroxine approximately 6 years of age. And you see their growth was tailing off, but gratifyingly now her growth has really improved and she's approximating the 50th centile for her height, which I think is a fantastic response. Her weight has also improved and dropped down the centiles as she's aging. Her basal metabolic rate has normalized, but you can see that this comes with quite a high dose of thyroxine. So she's up at 225 micrograms a day, which typically would be a very high dose for a 16-year-old. And you can see that her biochemistry looks like what we might typically see in a patient who's thyrotoxic. And again, that's because we're exposing her HPT axis to quite a high level of thyroid hormone. And we've got to remember that our thyroid function tests are only giving us information about the exposure of thyroid hormone to beta expressing tissues. And we have to use other parameters to guide us in terms of how much thyroxine to use for her. So the last form of RTH I'd like to describe is defective thyroid hormone transport. And the main form of this is MCT8 defects. So MCT8 deficiency is also termed Allan-Herndon-Dudley syndrome. And here the problem is thyroid hormone transport into the cells. And these patients have defective thyroid hormone transport through the MCT8 thyroid hormone transporter. And this transporter is critically important for thyroid hormone transport into the brain. And so these patients have relative cerebral hypothyroidism and very profound neurocognitive impairment. But MCT8 is not required for thyroid hormone transport in the periphery. And for reasons we don't completely understand, these patients tend to have a raised T3. And so they have a peripheral hypermetabolic phenotype. They can have a tachycardia, they tend to have low body weight, they've increased BMR, and they can have failure to thrive as well. So patients with MCT8 defects are almost exclusively male because the gene encoding the MCT8 transporter is on the X chromosome. The estimated frequency is 1 in 70,000 individuals, and it results in a very severe delay in cognitive and motor development. These patients have central hypotonia, spasticity, and dystonia. This is an example of some children who are affected, and the majority of boys never learn to speak or to walk, and they can't sit independently. It's a devastating condition. If brain imaging is performed, typically we see hypomyelination. These patients tend to have abnormal thyroid function tests. So the TSH is usually within the normal range, but the T4 is low end of normal or below that, and the T3 level is elevated. The average age of diagnosis is 24 months, but patients can be sometimes diagnosed later on in life, but the onset of symptoms is always in childhood. And sadly, these patients die early. So the median age of death is 10 years, with a range between 1 and 71 years. And the causes of death are typically respiratory, but sudden death is reported, and we suspect this may be due to arrhythmia. It's known that low body weight and lack of head control is associated with a risk of earlier death. It's very difficult to treat these patients, and there's no specific treatment really available for them. And so interest in the use of the thyroid hormone analog Triac came about. This is the same medication that I mentioned earlier. And the reason why Triac was hypothesized to be of benefit to these patients was because it lowers the TSH level and hence would reduce the T3 level and improve the peripheral hypermetabolic phenotype. And Triac does not require MCT8 to enter into neurons, and it can activate thyroid hormone target genes in a similar way to T3. So it was thought that it might be beneficial centrally as well. And so a phase 2 trial was performed internationally on 45 patients with MCT8 defects, and they were all treated with Triac for at least 12 months. There was median age of 7 years at enrollment, and the primary endpoint was to see if the T3 levels could be lowered. And indeed, Triac was very beneficial in lowering T3, as you can see in this graph. Secondary endpoints included body weight, and the mean body weight increased by almost 3 kilograms, and also the resting heart rate, which fell by 9 beats per minute. This trial was not designed to look at neurocognitive outcomes, but a second trial is ongoing at present, and children are being recruited at a younger age, and that the aim of this trial is to see if Triac would be helpful from a neurocognitive point of view. So this is a table summarizing the syndromes of resistance to thyroid hormone. I've included RTH beta, RTH alpha, and MCT8 transporter defects. And for completeness, I've also included selenoprotein deficiencies, which I haven't had time to discuss. The typical biochemical patterns are shown here, and the clinical features. And what I'd like to draw your attention to is that the biochemical pattern between RTH alpha and MCT8 are very similar, but the clinical phenotype is quite different. Patients with MCT8 are almost exclusively male, and they have quite a different neurological presentation, which is more severe. So usually they can be distinguished because of their clinical presentation, even if the biochemistry is similar. So I'd like to stop there. I'd like to just mention that we have done a review of monogenic thyroid disorders, which includes these disorders, and that will be available to download this year from Clinical Endocrinology. And I'd also like to mention that referrals are always welcome. So if you'd like an opinion on your case, either because they've got funny thyroid function tests or because you think they have resistance to thyroid hormone, I'm always very happy to receive those referrals by email, and you're very welcome to contact me. So thank you very much for your attention, and I look forward to a good discussion. Thank you so much.